certainly a very interesting talk, John. It's certainly, I have heard some of those alcohol figures before, particularly within the teenage years, so it's certainly an eye-opener, but it's very encouraging to see that there's groups there and people are working towards a strategy for it. Now, just before we get to our next presenter, Lynne, I forgot to mention how we're running today. We've got another presentation and then we're going to have a break for morning tea, and then we will be coming back to listen to 3 more presenters, of which there's some case studies in there, and then we're ending with lunch at about 12:30, between 12:30 and 1. So I'd like to introduce Dr. Lynne Millar, who's a Senior Research Fellow at Deakin University in the area of obesity prevention. Lynne's research interests are focused around developing and evaluating interventions that are aimed at changing systems around diet and physical activity to prevent childhood obesity. Today, Lynne is going to tell us about interventions for preventing obesity and encouraging healthy lifestyles, particularly in a rural context. Thank you, Lynne.
Hi everyone, as you said, Lynne Millar, and I'm a postdoctoral fellow, which means I just finished my PhD. I graduated from my PhD last year, and that was in obesity prevention. And I came to university late in life, so I've been all the way through, done my undergraduate, my honours and my PhD. But before that, interesting fact, I was on a farm between Dimboola and Nil at a little place called Kayata. Does anyone know that? Very, very rural and remote area out there. So, what I'm going to talk today about is the interventions we've done in the past and what we're doing now. So how big a deal is obesity? This is a bit of a pun. And is there an epidemic? Is there really an epidemic? What action's been taken? What's resulted from these actions? And what's next in interventions? And what's the latest evidence? So obesity, I can't really read it from here, but it's, as you can see, these are the latest figures from the Australian Bureau of Statistics, and the children from 2 to 17. And you see there's about between 20 and 28% of children are overweight or obese. So that's about a quarter of all Australian children are overweight or obese. And by geographic location, you can see where the major cities, it's the quarter, then inner regional it's a little bit higher, and then outer regional and remote it's up around 28%. And these are just kids who have been measured. It is representative, but we still think we miss out on a few of the more heavy kids that don't like to be measured. And we know it's an epidemic because you can see here in 1960, the rates of obesity were quite low. And then everybody in all age groups increased from about the mid 80s upwards. So there's been an exponential increase in obesity in all age groups. So what does that tell you? Anybody?
McDonald's.
Sorry? It's less activity? Yeah. A big change in diet to processed food, away from natural food. Yep. Anyone else? Fast food. I think McDonald's just celebrated their 40th anniversary in Australia. So they started around, yeah. But it also tells us that, contrary to what some people will tell you, it's not an individual responsibility. It's not an individual thing. Obesity just hasn't happened. There hasn't been a big change in genetics. There hasn't been what it is, there's been a big change in environments. So you have to look at environments when you look at obesity. You can't just say to people, like, do people who are in the rural and remote areas just eat more calories and exercise less? Is it that individual responsibility? I don't think so. So what I'm going to show you is how the epidemic has spread through America. I'm not that great with geography, so I hope there's some other people who are, but you can just watch down here. There's no data in the white squares. This is 10%, this is obesity only, not overweight. This is less than 10%, and this is 10 to 14% in the dark blue. So you can see it's spreading, the dark blue, spreading. Oh, it's taking over. Oh, so now we have to go to another colour. This is between 15 and 19% obese only, and we're up to 1991. So you can see it spreading. Oh, everyone's gone. Oh, now we're yellow, so we've got over 20% obese. Oh, now we've got up to over 25% obese. Oh, now over 30. So you see how it spreads through America. Is anyone good at geography? Okay. What is it about these states that are different to these states? They're what? Colder. They're colder up here. I was just here for a long time. It's cold there. What is it about these states?
Higher income and more cities. And Mississippi River, which is that's lower socioeconomic.
Lower socioeconomic. A lot of these southern states.
Kentucky Fried.
A lot of these southern states are low socioeconomic. And this is right out near Hollywood somewhere. And this is up like New York. So you can see that the obesity epidemic has hit the poorest states harder. And there's a lot more rural and remote too down here. So why does it hit the poorest states harder? Oh, thanks.
A bit more flexibility.
Thank you. Oh, good. I like to move. So why do you think it hit the poorest states harder? Is it because people in poorest states just eat more calories and exercise less? Yep. Lack of education? Yep.
Fast food is so cheap in America.
Fast food is cheap in America. I just spent 4 months there and I think I put on 4 kilos. Oops, embarrassing. It is cheaper and there's a lot more of it. So what have we done in Australia to try and stop this epidemic from happening here? So what we've done a lot of work around the Geelong area, the Barwon area, and we tried to build evidence on what works for whom and why in obesity prevention. So we use the Barwon Southwest region as a sentinel site for obesity prevention. If some of you went to school here, you're probably involved in some of the trials that went on. And so we worked with local communities, but we did all the evaluation of the trials. So as you know, this is Geelong here, and the Barwon Southwest, it's got a regional population of 300,000, and Geelong's got a population of about 200,000. We have this slide because we have delivered these presentations overseas a lot. So what did we do? We used a community capacity building approach. So went into the community and built their capacity to promote healthy eating and physical activity. And that was through professional development, leadership, through knowledge exchange like the data on obesity, and through things like working with canteens on healthy menus and stuff like that. So there's a lot of leadership and commitment, and a lot of funding went into it and resources. And it had to be multiple settings. It can't be just at school. It had to be at home and in the wider community. And it had to attack physical activity, diet, and sedentary behaviours all at once. So this is what happened. In Colac, it was Be Active, Eat Well, which was a primary school intervention at primary school children, and it was a whole town. And that went from 2002 to 2006, where it was evaluated in 2006, and then it was re-evaluated in 2009 after there'd been no intervention for 3 years to see if it was sustained. In East Geelong, it was It's Your Move, which was the subject of my PhD. So that was the high school students in East Geelong, and that went from 2004 to 2008. All of these had 1 year build-up before the actual intervention. And then Romp and Chomp was in the under 5s, and that went for the same time as It's Your Move. So this is what we based our interventions on. We had a logic model. So we said, we'll put an intervention in here, we'll build community capacity to promote healthy eating and physical activity, and that should impact on the knowledge, attitudes and beliefs of the kids, which changes their behaviours, which changes their body weight. And we're going to also go through environments to change behaviours, to change body weight. And this is quality of life, which we measured as well. This was to make sure that our interventions didn't impact negatively on people's quality of life, their mental, their mental attitudes and things. So what happened? Well, like I said, they were all participatory. So they were community-based. They were capacity building, 3 years. There's over 1,000 kids measured in each arm of the interventions. So, and we were looking for changes in anthropometric measurements, which was like BMI, and community capacity. So what we did some planning, and we went through prioritisation workshops. And this is what, we're just going to flick through these because they're not that interesting. So we did an Angelo process. This is what we did. This is so we could come up with an action plan for each of the schools or each of the settings. So most of the action plans were built on things that you would think were reasonable. More active play, more active transport, more fruit, more water, quality fast food. They went into shops in Colac and got them to change how they made their fast food. And social marketing, community capacity, and of course cut down on television, car transport, crisps, sweet drinks. So that all sounds reasonable, yeah? That's what we should do. Interesting thing, in America, anything over 500 metres, they'll drive. I think that's too far to walk. I'm quite surprised that we walked everywhere. So I'm just going to go through the results now. So this was Romp and Chomp. This was the under 5s. And it was great. There was a good intervention effect. So there was a relative reduction of 1.8 and 2.7% in overweight and obesity over the 3 years. And you can see that this is the intervention bars for the 2.5-year-olds and 3.5-year-olds. And you can see that they went down in prevalence of overweight and obesity, but so did the state. This was against the rest of the state. So in fact, the whole state dropped, which was great. But the intervention areas dropped more. So it looks like the intervention worked. It was a low budget. It was only like $100,000 over 3 years, which is a really low budget for any work. If you think about the health budget and what's spent on medications for diabetes and things like that. And there were changes in behaviours and environments, and like I said, the state prevalence of overweight and obesity decreased at the same time. And you can see it here more easily. This is overweight and obesity together, and this is overweight, and this is obese, and you can see that since 1999, the trend has been for a decrease, or there's a little decrease, but it's been a real levelling off of obesity in young children in Australia. Now, for Be Active Eat Well, which was the primary schools, you can see that compared to the comparison groups, which is at 0, you can see that there was a decrease in BMI, a decrease in ZBMI, which is BMI standardised for age and sex, weight and waist also. So it was really good. We saw some great positive outcomes in Be Active Eat Well as well. So there was a reduction of about 1 kilo, which is at a population level is a really fantastic thing. 3 centimetres in waist, which is great because waist is where you look at your risk factors for diabetes. And the good thing about Be Active Eat Well was that there was a greater effect in lower SES children. And this is about the first time this has ever been seen. And there was no differences in those safety measures I was talking about with self-esteem dieting. But was it sustainable? This is Colac that this happened in, and the comparison was the rest of the state. So what happened? So this is the Be Active Eat Well follow-up. It looks really messy. But this is each of the schools, and this is the difference in overweight and obesity over time, so between 2003 and 2009. And over here is where all these are sort of joined together. And you'll see that this is an intervention group, so there was still a decrease. The decrease was sustained. But you'll see in the comparison group, there's an even greater decrease. So that was the measures in 2009. So it looks like something's happened here for the intervention to spill over into the comparison area. And we think this is what happened. You see here, this is during the intervention phase. This is the money put into Colac, into the intervention area, and this was the money in the surrounding area in obesity prevention. After the end of the intervention, this is the money that got put into Colac for obesity prevention, so that much was withdrawn. But look what happened in the rest of the area, in the rest of the region. It's like they've suddenly gone, you know what, Colac's done such a great job with their obesity prevention, we really want to do something too. And so all this money has been put into the other areas, and there's been a drop in the prevalence of overweight and obesity in those areas. So we really need to put money into the areas of prevention. And this is It's Your Move. This is a high school ones. And you can see that this is a change in overweight and obesity over the time of the intervention. And you can see that intervention area went down and the comparison area went up. And from there to there, it's 5.8 percentage points. And there were big changes in community capacity in the intervention areas and not in the comparison areas. And there were changes in the school environments. But there were few significant changes in individual behaviours that we could measure. It's quite hard to measure changes in behaviours just because of a lot of statistical things and that. And all these results are, of course, adjusted for everything. And this looks really messy, but I'll just walk you through it. So on this axis is a change in overweight and obesity that we were talking about before, from the start of the intervention to the end. Along this axis is a change in community capacity. They were saying that we had to build community capacity before the intervention would affect behaviours and weight outcomes. So you can see the schools here, they're intervention schools, they're with the black, and they're the ones that increase the most in community capacity. So they had a 3-unit increase on the scale we used. But they're also the schools that decrease the most in overweight and obesity. So it looks that And you can see there's a bit of a dose effect going on here. So no change. This one didn't have many kids in the school, so the error bars are really wide. But you can see from here down, as community capacity increases, there's bigger decreases in the rate of overweight and obesity difference over time. So overall, we think that community-based interventions are effective and they're quite cheap. The under fives look like they're particularly responsive, and they're safe, and they probably reduce inequalities because it's aimed at everybody in the community. It's not just aimed at a few people. Behaviour change is often difficult to detect, like I said. And these were built on, we used champions for the intervention, and we probably need more leaders and champions throughout our communities to push the word. Is it sustainable? Maybe not. Might probably need to put more money into it. So what are we going to do next? We're going to move to a systems approach. So when you think about systems, you just think about a school system, any system at all. That's all I'm talking about. So, go back. So, as we said before, the systems surrounding obesity are quite complex. I probably didn't say that, but I meant to. In here, you don't have to read it all because you won't, but in here is energy balance. Like we said before, a lot of people just say it's easy. It's easy to fix obesity. People just have to eat less and exercise more. And that's this part here. So all these other things impact on obesity. And there's like things like individual psychology, social psychology, individual physical activity, environment surrounding physical activity, food production, all things like that. There's, I think, 7 or 8 different subsections. So we can look at this and throw up our hands and go, well, obviously it's all too hard. How can we ever do anything about obesity if we have to tackle all these things? Well, what we do is sort of try and break it down and tackle little bits of the systems, the subsystems surrounding obesity. So I'm just going to walk you through one thing that we've been working on in the ACT with schools up there. We're trying to do a systems intervention up there into obesity prevention. So we're taking into account not just going into school and say, hey, you, change your menu, hey, you know, do things like that, put in more water bubblers, whatever. So I'll just walk you through one system change that we're looking at. So everyone knows red foods and drinks are categorised as dense, have high calorie, no nutritional value. Most are high in saturated fat, sugar or salt or everything. And green foods are excellent sources of important ingredients, nutrients, and they're those sorts of things, fruit, vegetables, water, everything everybody knows about. So you go into a school and you say, you've got really high red food intake, what are you going to do about it? Why have you got a high food intake? Because kids choose red foods and red foods are available from the school canteen. Well, they're from home, from the surrounding shops and from the school canteen, or from the school actually. But we're not going to do much about these, but we're going to concentrate on the school environment. So where are they? They're sold in canteen, they're used as rewards in class, they're sold at special events. And why are they sold at special events in the canteen? Because there's high demand for them, but they also cross-subsidise other activities. Like they might cross-subsidise a bus that goes to sporting events, so you have to be quite careful what you're going to do here. Why are they eaten? Because they're cool, because they're cheap, and because they're really normal. Like us older people in the audience would remember when we were young, it wasn't normal to have takeaway food, or it wasn't normal to have red foods at all. In fact, it was very abnormal. So this, we're starting to build up now the system that's surrounding the red food. So the canteen cross-subsidises other events, so it needs to be profitable. And they're also usually outside people, outside providers, so they work for profit. The food industry is for profit. And the goals of the management, school management. And also we found that staff really model red foods. A lot of the teachers would go out at lunchtime and come back with McDonald's or whatever, and the kids would see it and think, oh well, that's okay then. Red foods are common at home. Like we said, they're cheap. So, but what does the principal want? The principal wants student behaviour, and if you follow the pathways down, actually bad student behaviour goes with a lot of red food. And also the principal wants better NAPLAN results. Better NAPLAN results go with better good food. There is evidence around that, you know, healthy eating improves NAPLAN results. So what are we going to do? So we brought in a coordinator whose job it was to try and intervene in this system to make more green foods available at the school and sold at the school. And there'd never been the canteen manager had never met anyone on the school management committee, so nobody knew what anyone else was doing. So we brought in new networks and partnerships and things like that. And then we said, well, what can we see what's sold in the canteen? And no one had ever looked at the sales data before. So we go back through the canteen manager, back here, back there. And because it has to be profitable, the canteen manager then spoke to the school management, and it was decided that the canteen didn't have to pay any rent for 6 months while they implemented these green foods. And also you had to watch out, by mapping out systems, you can see what unintended consequences might happen. And so, because it's cross-subsidised other activities, had to figure out how to get more money to cross-subsidise, to subsidise these activities rather than it coming from healthy, unhealthy food sales at canteens. And they brought in lots of healthy options for fundraising and things like that. And it's really worked quite well. But this is the current situation. This is data that we have just collected throughout the whole of Victoria, mainly in lower socio-economic LGAs, local government areas. This is just, if you use the WHO growth standards, you'll see in grade 4, 39% of kids are overweight or obese, and in grade 6, 36% are. But if you use IOTF, you get 30 and 27. The difference between these two things, that WHO ones are more recent than the IOTF ones. And the WHO ones are standardised on how kids are meant to grow in an ideal situation, like breastfed for 6 months and mother didn't smoke or drink during pregnancy and things like this. So so people are more tending towards these more than these because they think it's a more realistic figure. So if you use a more realistic figure, it's really high. Met physical guidelines, 26% only in grade 4 and 33. And these are the Australian guidelines. Met screen time guidelines. These are 5 or more days a week. These are going quite well at this stage. You should see the high school ones. Not so good. Met vegetable daily intake. Whoops. I think the high school ones you're down to 2% or something like that. Fruit's good because that's pretty easy. That's only two pieces a day. So think about your own vegetable intake, and there's hardly anyone who meets the 5 veggies. And we don't want people to meet 5 veggies by just adding that on top of what you're already eating. We want people to substitute what they're eating and eat more vegetables. So that's it. Any questions?
was such a huge part of their income. It was literally a matter of survival.
Yep.
And if we look at now, food has become irrelevant to our incomes. We'll spend more on travel and flying around the place. Not only do we have this capacity to purchase more food, we have a capacity to purchase more energy-dense food.
Yep.
We waste 25%. So to me, that means that focuses on exercise are probably not going to be enough. We have to have work on education, we've got to see the pricing, the health system, those sorts of things. Do you broadly agree or disagree with that relationship between income and food is a major contributing factor?
The relationship between income and food is a major contributing factor, but it's the lower your income, the more likely you are to buy energy-dense food. And so, because you get better bang for your buck. It's more filling. It's more filling to go and buy a $2 McDonald's hamburger than it is to buy 2 apples. And it's a bit of a perception thing too, though, because people think it's cheaper to go and spend $20 on takeaway food when you could actually cook a meal, and that comes down to education and things like that. So there's a big perception out there, but the perception is because there's so much advertising out there pushing people to consume and overconsume energy-dense food. And you'll see it's in a lot of poorer areas. Like if you go to Toorak, there won't be a McDonald's on every corner, or a Hungry Jack's or Kentucky. You go to Werribee or somewhere like that, and there's one, there's 15 in 2 blocks or something like that. So it's the environment that pushes people to overconsume as well.
I might borrow this from you.
Yeah.
We've got another question here.
A little bit of a question, a little bit of an observation. So when I was a child,
Yep.
when you got off the school bus, you walked home. If you lived in a small town, you walked to school. And I think that's part of the issue, that no longer do parents feel comfortable in allowing their children to walk alone. The other thing that I see is that too many young people have got no idea how to cook.
Correct.
They have no idea of how to utilise the stem of the broccoli and the stem of the cauliflower and make a bit of soup. That all goes in the rubbish. We don't use that. No, that's off. So what's your view?
I agree that children don't do enough incidental exercise, or people don't do enough incidental exercise nowadays. The cities are made for people to drive everywhere. There's shopping malls and things like that. And there's a lot of places where there's hardly any footpaths or safe bicycle tracks or anything else. And the children's not walking to school or riding their bikes. Well, it's busier on the roads for a start, but so if less people actually drove their kids to school, it would be safer to ride your bike to school. But there's also a perception of stranger danger that just isn't, there's no evidence to support that. There's no more children getting kidnapped than there was in the 60s. There's a lot more media about any incident that happens, but there's in actual crime figures, there's no more crime against children now than there was years ago. It's perception, and it seems to go, parenting has changed a lot in the last 40 years.
Got another question from Ian.
Ian Blair again. Your comments on Stephanie Alexander's work with growing veggies in the school. I've got 5 grandchildren, and by giving them each a little plot and they grow their veggies, and then they're told go out and bring it in and eat it and cook it and things, and they're only under 5, so it seems to me that if we can make it attractive, that can go towards correcting the problem. Are you working with Stephanie Alexander?
We're not working with Stephanie Alexander, but I do know the program. It's a very good program. A lot of the schools we're working with in the ACT, the primary schools, are putting in their own school gardens, And I think it's a terrific idea. We're working a bit with the Jamie Oliver program, but yeah, just that. Yep.
I'll get to you, John, in a minute. I'll give.
I'm just wondering why it's a problem in the rural areas. I mean, kids have always caught buses to school in the rural areas. They're probably more active in the rural areas because they're not in front of the TV as much as cities. There's no access to takeaway food as much. Well, there's no McDonald's in a lot of rural areas. I know my kids go to primary school and their school canteen was closed this year because they couldn't provide healthy foods. So, yeah, and they're all involved in sport.
Yeah, during It's Your Move evaluation, I read a lot of the same comments from people in rural areas, and a lot of people said, if you look around our school, all our kids play sport, they're really healthy. If you look around, you'll see there's hardly any overweight and obesity until you measure it and go back and say, well, in fact, people's perceptions of what overweight and obesity is when they look at their children has changed a lot. They see kids who are normal, within a normal BMI range, as being skinny. Whereas in the 60s and 70s, everyone was skinny. And then they see people in the overweight range as being in the normal range. And they see people who are obese as being in the... And it's not until you see people like on The Biggest Loser where people go, oh, well, that's obesity. That's not obesity, that's morbid, super obesity. Obesity is when you look around and people are, I'm not going to look anywhere, and people are like 30, their BMI is 30, you've got to know your BMI as adults. You've got to know your waist measurement, because then you'll get a true idea of what obesity is. Weigh your kids, measure your kids, and then you'll see what it is. True, people's portion sizes of their meals has gone up. People eat a lot of meat and a lot of potato and things like that, whereas we advocate to look at your portion sizes. A piece of meat, should be this big. If your kids play sport, it doesn't mean they should come home and drink soft drink and eat spaghetti and things like that. It's really hard, but I get it as an environmental issue. Why is it different in rural? I don't know. And this is what we're trying to unpack at the moment. We've just collected data from all over the state, and what we're doing is this fancy modelling to try and pick out differences at the LGA level and differences at the individual level, to try and explain why some LGAs, especially the rural ones, why the obesity is bigger there, because we really don't know the answer to that. Yep.
Dan from FX Media. So the sample sizes that you have, I mean, obviously you've got your regional and then you've got your rural areas. Yep. Do you think that rural is being a bit skewed by regional statistics? Is it being lumped alongside the regional towns where they've got more access to the fast foods and screen time? Whereas has there been individual, research done solely on rural areas where you might find that it's not as bad, or maybe? Well,
that first graph I showed was from the ABS, and that actually pulled out remote, and then the in a regional, sort of like Geelong, Bendigo, Ballarat was lumped together, and then urban. So it's definitely worse in the remote. Yep.
Okay, thank you.
And it's more like urban Geelong would be more like Melbourne. Yep.
We've got a question up the back from Des, but I've got this here, so you're going to have to yell. I'm not going to walk up there.
That's probably a comment on the last 20%.
Yeah. Yeah, I guess the point is it's a big problem everywhere, and that's why we're trying to work with whole of communities to try and get, well, at the moment we're working with the whole of the state to try and get everybody on board. Like John says, we really need grassroots movements where people go, you know what, we want health for our children. We want health for ourselves. We want our environments to be healthy. We want our environments to push everybody towards good health. And at the moment they're not. And I think it may be not useful to try and point the finger at sort of COLAC or rural and remote or anything like that. What we want to do is work together to promote good health everywhere. And in some special circumstances, like special, you might need to push a little bit different. Like you said, there's no, takeaway food around where you live, so it's something else that's driving the obesity. So we've got to work together to find out what they are, so we can bring the levels back down.
Okay, Lynn, I might leave it at that because we've got a chance right at the end of the forum to have all the presenters up in a panel. So let's put our hands together for Lynn. Thank you very much.